All right, in this recording, we're going to talk about medications that we use to treat diabetes. So first, review your patho on diabetes. Remember, we have two basic types, type 1 and type 2. There are, we have like gestational as well. So review those if you need them. Review your signs and symptoms. Here's your patho review for type 1. I also put a little thing in here about DKA because we're going to talk about what we use to treat all of our emergencies, our diabetic emergencies as well. Remember that with type 1, we don't have beta cells secreting insulin, so they have to have insulin. Whereas type 2, we have it is a resistance to insulin rather than a complete lack of insulin. Gestational diabetes is specific for pregnancy. You got to give insulin in order to prevent birth defects. About a third of those patients who get gestational diabetes end up with type 2 diabetes later on in life. And with gestational diabetes, we have to treat that with insulin. We can't give them PO, oral hypoglycemics. Got to actually give insulin for that. Long-term complications, remember that we've got macrovascular and microvascular changes, and then when we're talking about emergent situations, you've got DKA with our type 1 diabetes and HHS or HHNS in our type 2 diabetes. We talked about both of those in Patho. Here's a comparison chart for those. When we are screening for diabetes, we are looking for people who have elevated A1C levels. That is your average blood glucose level over about 3 months. Average is between 2 months and 4 months because it's based on the life cycle of a red blood cell. People who are at increased, and then we also would look at fasting glucose levels. People who have pre-diabetes have an A1C between 5.7 and 6.4. Their fasting glucose levels are between 100 and 125. And then once they actually are diagnosed with diabetes, it's an A1C of 6.5 or above, or a fasting glucose of 126 or above. And our treatment goals are to get that back down to a normal fasting glucose level and to get that A1C less than 7. So all of our medications are aimed at that. Remember, we always try lifestyle changes with type 2 diabetes first. Those don't work with type 1 diabetes. This one here, I put this on here even though it's more like what you're going to learn in your nursing class as opposed to this one, but I liked it, so I wanted you to have that for later. All right, when we're talking about our types of medications, first we're going to talk about insulins. Insulin is an injection. It is given subcutaneously for the most part. We can give insulin IV. When we give insulin IV, it is always regular insulin. NPH insulin was one of the old ones, and that is an intermediate acting insulin. It's cloudy. You know it's intermediate acting when they're cloudy. And then the short acting insulins are clear. So we've got an insulin table on Blackboard. Please refer to it. You need to know your peak, your onset, your peak, and your duration of all of those insulins, okay? You need to know it for this class, you need to know it for the HESI, and you need to know it going forward. This is something that is a pretty highly tested area. The way we'll ask questions like that, they're not going to be what is the peak of, insulin Lispro. It's going to say how soon after giving the insulin do you need to make sure, might the patient start experiencing symptoms of hypoglycemia? Okay, so things like that. All right. Oh, and in my class, I'd mentioned Nancy Reagan RN. So N is for NPH. When you have a multi-dose vial, so you inject air into it first. And so that's how I learned it, because you injected air into N, air into R, and then you drew up R, you drew up N. It's to prevent them from mixing. But anyway, I need to mute my computer, sorry. Always draw up the clear before the cloudy, okay? So remember that. It's a little thing that they can catch you on, okay? Now, when we're talking about anti-diabetic drugs, we're going to move on to PO anti-diabetic drugs, PO hypoglycemics, but some of the newest medications for type 2 diabetes are injections. They're just not insulin, okay? All right, so when we're talking about insulin, this guy here, here's some of the major types of insulin right here, okay? Insulin Lispro is our super fast acting, okay? This is our rapid acting insulin that we give right with a meal, okay? Regular insulin used to be the fastest thing we had, but that takes about 30 minutes to kick in, okay? Rapid on your insulin Lispro only takes about 10-15 minutes. So NPH is one of our intermediate acting insulins. It doesn't kick in for about 3 hours. And then Lantus has no peak, okay? It's a steady state insulin. We give it at bedtime, and it mimics our natural level of insulin in our body, okay? All right. Let's see. Just as an FYI, we make insulin using recombinant DNA, but one of the things that and it probably still exists, but not all insulin is recombinant insulin. Some people still get insulin from like pigs and cows. So that's kind of interesting. I don't know. All right, rapid acting insulins. These are our onset of 5 to 15 minutes. You need to know that it's Ilispro and Aspart. Sorry. Those are our rapid acting insulins. Okay. Their onset is 5 to 15 minutes. My general rule when it comes to insulin Lispro with your rapid onset insulin is don't give that injection until you actually see the breakfast tray sitting on their table or walking into the room, okay? Now, remember that here's your rapid acting insulin, here's your Lispro, and here's your regular, okay? It doesn't start for 30 or 60 minutes, okay? And it doesn't peak for a couple of hours. Lispro, if they don't eat, you're going to have a problem. Both of these can be given subcutaneously, Lispro and regular insulin. However, regular insulin is the only one that we give through an IV. When would we give insulin IV? If their blood sugar is extremely high and they're in diabetic ketoacidosis. That is always regular insulin, not these super fast insulins. Another rapid acting insulin is actually an inhaler. It's a Freza. And it peaks in about 12 to 15 minutes. They inhale it and they have to hold it in. It's contraindicated in people with lung diseases, and it has a black box warning about the risk of acute bronchospasms. So we definitely don't give it to people with COPD or asthma. I was looking for this picture, actually I wasn't looking for the picture. I was looking for more information about this because I truly had never heard of this medication until I read your book. And I saw somebody had a blog about it, and they were in a restaurant and they inhaled their insulin, and because you have to hold it in for a certain amount of time, some woman asked them if they were vaping in the restaurant, and then she got mad because she didn't answer her because she had to keep holding her breath. So I thought that was interesting. Here's your table that kind of shows how the insulins peak and then where they last. So here's your rapid acting. Remember, these are Lispro and Aspart. I always want to say aspartame. So there's your rapid acting. Look how fast it peaks, and then boom, it's down. It's out of your system. Regular used to be what we had, right? So it peaks a little bit after that, lasts a little bit longer. NPH is that intermediate acting stuff here. And finally, Glargine, which is Lantus is the brand name. See here, it's got that steady state, okay? Last 24 hours, about over here somewhere is where you're going to give yourself another injection. We actually give that at bedtime, and that provides that nice steady state. One of the interesting things about Glargine is that Unless they're going to be NPO for the entire 24 hours, we probably won't hold it if they're going to surgery. All right, now fixed combination insulins. These have an intermediate insulin along with a rapid insulin. Okay, so we have Humalog mixes that are 75-25. And then we have NPH and regular insulins that are like 70-30. Some other things that you need to remember, and with the things that are, these are pre-mixed, by the way, I should clarify. This is not you mixing them together in a syringe. The only ones you should never mix together, Lantus can never be mixed with anything, okay? And most places don't mix Humalog with anything either. That's the Lispro, okay? Some people will have something called sliding scale insulin, okay? And that is what you are giving the patient. And it can be used with either regular insulin or your Humalog. And the patient will it'll say AccuChecks before meals and at bedtime. And it'll give you a sliding scale. And a lot of them start at either 150 or 200 when their glucose is that level. And you give a certain amount of insulin to cover what the blood sugar was then. Now, the other thing that we do is with that blood, we also inject Humalog or regular based on the amount the patient is going to eat. This is actually the way people dose themselves with insulin pumps. They have a continuous basal dose of an insulin through an insulin pump, and it's usually Humalog that's in the pump, one of those rapid-acting insulins. And then before they eat, they check their blood sugar. They may correct it with a sliding scale, but then they look at the number of carbs they're going to eat, and they bolus themselves through the pump, okay? The disadvantage to sliding scale insulin alone is that it doesn't, if you don't have boluses for the meal itself, then you have to wait until that blood sugar's high before you treat it, okay? Which is why most people in the hospital bolus based on the number of carbs they're going to eat. And that's the new way to treat for diabetic patients. Here's the insulin pump. So this is the Basal-Bolus insulin dosing. A lot of people will also be wearing a CGM, a continuous glucose monitor. It relays information back to the pump. It just has to be on the same side of the body, I think, to accurately measure it. And then that continuous glucose monitor, they do still check their blood sugars periodically to make sure that it's calibrated correctly, but it'll alarm at them if their blood sugar gets low. Nursing implications when it talks about insulin. Always know what your patient's glucose level is before giving them insulin. We don't shake them. The ones that are cloudy are suspensions, okay? And so you roll them between your hands rather than shake them to mix them up. Insulin needs to be stored for long term in the refrigerator. Up to 30 days, though, it can be stored outside of the refrigerator. So the insulin vial that patients are actively using, that's usually not in the refrigerator. Only use insulin syringes because they're calibrated in units. Most insulin syringes are U100, meaning that there are 100 units per ml. Never use a regular syringe for them. And then always make sure you time it right based on their meals. Most people, most hospitals have a double check system in place for insulin. You have to co-sign that with another nurse. So in some places it's just a little note, and in other places they have to tap their badge so that both badges are signed off in Epic. And then anytime you've got patients getting insulin, make sure they know about not only how to inject the insulin, but they also know how to check their blood sugar. They know the signs of hypoglycemia, and that they understand, when to eat, how much to eat, all of those things. All right, now let's move into oral anti-diabetic drugs. These are used for type 2 diabetes. Remember that insulin is a mandatory medication for anybody with type 1 diabetes. Oral anti-diabetic drugs, remember that first they have to try lifestyle changes, okay? And then at that point, if those don't work, they will start them on oral anti-diabetic drugs. The first one that they'll give them is metformin, and then they monitor A1C levels, fasting glucose levels, postprandial glucose levels, and then they'll slowly add in different medications just based on what those are, your patient status, things like that, okay? But here's your lifestyle interventions. Here's your oral biguanide. That's the category. And then we use new medications at that point, okay? Remember that people who have type 2 diabetes often have comorbid conditions, including hypertension and high cholesterol. Everybody who has type 2 diabetes should be on a cholesterol-lowering agent, and they should be on an ACE inhibitor. The cholesterol-lowering agent is to protect them from heart disease, and the ACE inhibitor is for renal protection. Okay. All right, biguanides, the very first medication we're going to put them on, metformin, which is marketed under the brand name Glucophage. Biguanides do several things. The one thing that they don't do is cause your pancreas to secrete insulin. So because of that, they won't cause hypoglycemia. Instead, what they do, instead of causing your pancreas to release insulin, they decrease production of glucose by the liver. They decrease the amount of glucose we absorb in our intestines. That actually is why they can cause diarrhea as a side effect. And then they decrease insulin resistance by the body cells. And when you decrease insulin resistance, you allow the tissues to take up the insulin better, which then, since insulin is a carrier protein, it carries the glucose into the cells and out of the bloodstream, which then lowers your blood glucose. Typically, though, it's not enough to cause hypoglycemia. All right, adverse effects. I talked about diarrhea. Can cause a metallic taste in your mouth, reduced B12 levels. Let's see. And I figured out in my class that these are all in there twice. So there you go, adverse effects. I'm not sure why they were duplicated there. All right, moving on to the next category. These are our sulfonylureas. These are really old medications. They've been around forever. They all end in ide: glimepiride, glipizide, glyburide. These actually stimulate the pancreas to release insulin, okay? So this causes our blood sugar to be lower because you've got higher levels of insulin circulating through your body, and that carries more glucose into the cells, okay? So you can take a look at the little cartoony things that I put on there for you. These medications, if your patient is allergic to sulfa drugs, they might not be able to take this. And if they take these along with a sulfa antibiotic, then they need to keep a really close eye on their blood sugar, okay? All right, the glinides. These work similar to sulfonylureas, and they just end in glinide instead of ide, okay? They don't have a whole lot of common side effects, but they can cause some headache and dizziness. Both of these medications can cause hypoglycemia, so you have to teach your patients about the signs of hypoglycemia so that they can tell when their blood sugar is low and that they need to eat. A lot of times when somebody's blood sugar is getting low, they don't realize it until it's too late. So you need to be able to have them be able to recognize the early signs so that when the later signs get there, because at that point they're confused, they're not going to realize that they need to eat, okay? So you got to show them the early signs. All right, now our glitazones, pioglitazone and rosiglitazone. So these medications are not highly given anymore. And I'll tell you why. It turned out that they were causing, I told my class it was heart attacks. It's not, it's heart failure. And so I actually looked this up to see what the status of Avandia was, the resiglitazone. And because I remember when it was pulled off the market about, I want to say it was probably 7 or 8 years ago, it was pulled off the market, and the only people who could take it were people who like basically signed a contract saying they wouldn't sue the drug company if they got heart failure. And I mean, there's so many other medications available that really, why would you take something that had that higher risk of heart failure? But it looks like some of the newer studies say that it might be okay after all, and that they're lifting some of those restrictions. I was just looking it up online. So anyway, the way these medications work is that they inhibit the glucose production in the liver, decrease your insulin resistance, basically make you make your skeletal muscles take it up a little bit. Adverse effects: they cause liver failure and they cause weight gain and edema, leading to the heart failure. Okay. Alpha glucosidase inhibitors, these are not given very often either. And this reminds me of the Rolling Stone album. And I meant to actually put the Rolling Stone dude on there. I'm going to pause for a second. You'll never know. Okay, surprise, I changed your screen. In my class, I was making a comment how this one reminded me of the Rolling Stones lips symbol, and then I just put Mick Jagger on here for you with his mouth open. But Steven Tyler has a better mouth, so there you go. All right, anyway, alpha glucosidase inhibitors, these are not given very often. You take them with food, and they can be in combination with other medications, but you take this with the first bite of every meal, and it prevents you from absorbing some of the glucose that you take in. Causes flatulence, diarrhea, and abdominal pain. They don't cause hypoglycemia because they do nothing with insulin. Okay, they just prevent you from absorbing the glucose. And they don't cause the weight gain that sometimes we saw with some of the other medications. So they're not very common at all, though. All right, starting to get into some of the newer drugs that are getting pretty popular here. We have our DPP-4 inhibitors. These actually delay the breakdown of incretin hormones. And what do incretin hormones do? They actually increase insulin synthesis. So if we prevent their breakdown, then they're in there longer, which means you're going to synthesize more insulin. And they also help to lower the glucagon secretion by the liver. This reduces both your fasting and postprandial glucose levels. We will see hypoglycemia with these. You got to be careful. Teach your patients the signs, especially if they combine these with a sulfonylurea. Sometimes this is going to be the third medication your patient is on. Okay. These all end in gliptin. Okay. So the most common one I think is Januvia. Maybe that I just recognize that because it was the first one, and so that's the one I would see everybody on. So, all right. When we were talking about these oral anti-diabetic drugs, just like insulin, always check your blood sugar before you give it. Usually we give it with a meal, about 30 minutes before. A lot of them take a couple 3 hours to peak. Most of them have to be taken more than once a day. Not most of them. I'd say half of them. We're going to get into some other kinds too. Let's see. Metformin will cause nausea, so we give it with meals. Another thing metformin will do is it will interact with the contrast dye that we use during like CT scans, angiograms, and so we have to discontinue it 24 hours before and 48 hours after. They have to stop taking their metformin. Otherwise, we can put somebody in acute renal failure. So if your patient, you teach your patient the signs of hypoglycemia and teach them what to do. And that is take a glucose tablet. So tell them to drink some juice, chew some glucose tablets, and then also eat something that is longer acting. So eat something quickly to get your blood sugar up, and then move on to something longer acting. If they are unconscious, please don't put orange juice in their mouth or a glucose tablet and then they choke and then they die, okay? In the hospital, we will give D50. We'll give an amp, usually a half an amp of D50. That is 50% dextrose. That goes in the IV. Patient doesn't have an IV, give them some glucagon. Glucagon can be given IV or IM. Outside the hospital, if a patient is unconscious, every diabetic patient, every type 1 diabetic patient who is on insulin, but really every diabetic patient should have glucagon on hand for family members to administer in case of an emergency, because you don't expect your family member to call 911 and wait for the life squad to start an IV before they get before their blood sugar gets up. And so glucagon comes in a little IM injection. They just stab it into their leg. All right, so now let's talk about some of our injectables. And actually, I think there's one more PO med coming up that I forgot was later. All right, our first injectable medication we're going to talk about is an amylin agonist, and this actually, so it mimics amylin, which actually suppresses, it slows down gastric emptying. So it causes your food to be in your stomach for longer, so you get full faster and you stay full longer. This allows people to both lose weight and lower their blood sugar because they eat less, okay? This is a subcutaneous injection. Pramlintide, the brand name was Simlin. It can cause nausea and vomiting because it's severely slowing down the processing of food. And so when people first started, they were eating normally, and then they would get all pukey because it was like they went to the golden feeding trough for dinner. So that's what my dad calls Golden Corral. All right, our incretin mimetics, our GLP-1 receptor agonists. You'll notice on your slide, I added that in. They are better known as GLP-1 receptor agonists now instead of incretin mimetics. We used to call them incretin mimetics when there was just one, and that was Byetta. Now we call them the GLP-1 receptor agonist. Why? Because we're confusing you. Anyway, this mimics the incretin hormones, which which stimulate the release of insulin from the pancreas, but they also slow gastric emptying. They are pretty helpful in getting people to lose weight. These are injectables. They come in single dose injectables. I don't know how often Byetta is given. I don't remember if that's daily or not. Victoza and Trulicity are both weekly injections that your patient will do. So they'll get like a box. I guess they'll get a box of them, and they'll have like 1 month supplies, like 4 of them. So, and then always make sure your patient has a sharps container to throw them away in. Teach them about the effects of hypoglycemia just in case. All right, our SGLT2 inhibitors. These are PO drugs, okay, that I really should move up. So this is a new class of medications that I don't think is in your book. And what these do is they inhibit SGLT2. And what happens and that's the sodium glucose cotransporter, okay? Basically what happens in these medications is they make your kidneys excrete out all the glucose. So these patients are peeing out a ton of glucose, okay? How much glucose are you supposed to have in your urine? None. Okay, how much, because if you do have glucose in your urine and you're not on one of these medications, it's because your blood sugar is really high and it's actually spilling out into your urine. If you're on this medication, though, you're supposed to have glucose in your urine, and therefore it decreases your blood sugar that way. They also can cause some weight loss. So, and they really don't cause a lot of hypoglycemia. I had a patient once who was on one of these, and she said, "Yeah, I'm just fine unless I forget to eat." And I was like, "Oh, okay. I wish I had that problem, but you know." Okay, hypoglycemia. Here's your symptoms to teach your patients about. Okay, remember, teach them the early symptoms, not the late symptoms. Mild cases is, and this should not say hypoglycemia is below 70. So once you get below 50, your patient is probably not going to be able to just drink some orange juice. Okay, I already told you about the things that we use to treat it. All right, so our first one that I was telling you about is glucagon. So here's your little, I like this, glucagon when the sugar's gone, okay? So glucagon is that injectable one, remember, that I was telling you about. And and what we tell patients, what we tell family members is just, inject it through their clothes. It's an emergency situation, okay? Always tell them to make sure it's actually their blood sugar. Tell them to check their blood sugar. You don't want to be injecting glucagon in somebody and waiting for their blood sugar to come up when they've actually had a stroke or something. The other things we can give to elevate glucose are D50. I talked about that. You got to have an IV, okay? And then oral forms of glucose if they are talking to you, if they're alert, okay? If their speech is slurred, they're going to choke on them. So, I think everything else is pretty self-explanatory, and I talked about it with the other stuff. So, overall nursing implications. We're going to monitor A1C. If your patient is started on a new diabetic medication, we're probably going to wait 3 months before we check the A1C level. Now, every once in a while, if you've got somebody who their blood sugar, their A1C was really high, like 10 or 11, they may start them on a medication and have them come back in a month. No, they're not going to see the full effect, but that A1C should be coming down, okay? And if it's not, if it hasn't come down at all in that first month, they're going to be putting them on insulin, okay? All right, review questions. Patient with type 1 diabetes is admitted to the medical unit with an acute exacerbation of COPD. He's placed on IV piggyback antibiotics, nebulizer treatments with albuterol, an IV corticosteroid, probably methylprednisolone, and he's also taking a proton pump inhibitor for GERD. So remember our prazoles there. He takes a dose of glargine insulin every evening. That's Lantus is the brand name there. This evening, the nurse notes that his blood glucose level is 170, and the next morning, his fasting glucose level is 202. What is the most likely cause of his elevated glucose levels? Pause and answer this to yourself. Pick a medication. Hopefully you said D, the corticosteroid. Steroids antagonize the hypoglycemic effects of insulin. They will raise your blood sugar, okay? That's cortisol's role. Well, one of cortisol's roles in the body is to raise your blood sugar as part of the stress response so that you have enough energy to run away from the bear. After the 0700 report, the day shift nurse notices that a patient has a 730 dose of insulin due and goes to the automated dispensing machine, otherwise known as the Pyxis, to retrieve the insulin. The nurse sees that the night shift nurse had removed the 730 dose of insulin, but the medication administration record has not been signed by the nurse. The night shift nurse didn't scan it. The patient's confused and says, "Well, I think that nurse gave me the insulin. The glucose level is 142. What do you do as the day shift nurse?" Pause, answer this to yourself. And the correct answer is call the night shift nurse at home. All of us who have worked night shift have received one of those phone calls. Why does it suck? Because you're usually in bed. If you call the day shift nurse, if the night shift nurse calls the day shift nurse, a lot of times the day shift nurse isn't in bed yet. Just, as an FYI. All right, a woman who has type 2 diabetes is now pregnant. She wants to know whether to take her oral anti-diabetic medication. What instructions will she receive? That will be C. Remember, are diabetic people with gestational diabetes or people who are diabetic and are pregnant, either way, they get insulin. The nurse had just administered the morning dose of a patient's Lispro insulin, that's Humalog. Just after the injection, the dietary department calls to inform the patient care unit the breakfast trays will be 45 minutes late. What will the nurse do next? That nurse will slap herself upside the head for giving that patient's Lispro before they saw the breakfast trays arrive on the unit and walk into that patient's room. All right, what do you do as the nurse? D, you gotta feed your patient. That's why we keep food on the units. All right, one case study. A male patient who has a history of type 2 diabetes is admitted to the medical unit with a diagnosis of pneumonia. Patient has many questions regarding his care and asks the nurse why everyone keeps telling him about about hemoglobin A1C. Nurse will inform the patient that A1C provides information regarding C, patient compliance with treatment regimen for several months previously. The patient was taking metformin before this hospitalization. To facilitate better glucose control, the patient has been switched to insulin therapy while hospitalized. The patient asked the nurse, why is it so important to time the meals with the insulin injection and to give him an example of a long-acting insulin? Which drug will you tell the patient is a long-acting insulin? Pause. Answer it to yourself. That would be Detamir. Detamir is a long-acting insulin. Apidra is rapid-acting. NPH is intermediate-acting. And regular is short-acting. Patients being discharged home with insulin aspart and insulin isophane suspension. Which information does the nurse include when providing discharge teaching to the patient? Pause and answer this to yourself. That would be D. You draw up the short-acting insulin first and then the NPH. Now, I'm going to put a little caveat on this question. This case study was in your book. However, I was always taught, and there seems to be two schools of thought on this, you do not mix aspart with NPH. You give it separately. There seems to be two schools of thought on that. So it sounds to me like that was the general rule, but as it was out for a while, somebody probably mixed it, figured out it still worked. So the nurse enters the patient's room to complete the discharge process and finds the patient to be lying in bed, unresponsive, but breathing. Blood glucose level is 48. What's your most appropriate response? It's definitely A, putting sugar in the patient's mouth. Start CPR. Nope, not when they're breathing. Roll the patient to the side and administer the ordered glucagon or have the patient drink orange juice. You let me know next time you're unresponsive whether or not you can drink orange juice. That would be C. Give them glucagon. Why do we roll them onto their side? Same reason you roll somebody on their side after they pass out from drinking. It's so that they can't aspirate. And adrenal drugs will be in the next narration.